I'm just going to share my screen here, and we'll just go ahead and get started. I'll be sharing out these notes right after the call. So welcome to our health department updates. Oh my goodness, it is a busy time. So just in terms of the agenda, we're going to update everybody on COVID very quickly and address any questions you might have. And then we have some monkeypox updates and then several miscellaneous infectious disease updates as well. In terms of COVID, I think that we are cautiously optimistic that our numbers will improve. I know that our hospitals are not seeing that reality yet. The reason that we are cautiously optimistic is that statewide, the numbers are improving in terms of COVID case counts and hospitalizations. And locally, we're seeing several data points that indicate that the wastewater surveillance is now downtrending as well, which it really hasn't done all summer. In terms of the testing positivity, we can see that the latest bend in the curve is coming down. We know that both the wastewater surveillance and the testing positivity usually precede what we see in terms of the case counts and the hospitalizations. The hospitalizations themselves are also showing a slight downward bend from a peak this summer in the 240s, 240 patients hospitalized across our 7 acute care facilities to just above 100 at this point. So for what it's worth, we know everyone is really impacted at the hospitals. We know that things are very busy there. This is just what the numbers are indicating right now. So that's really the best indication we have about what's going on. More importantly, there's been just better and better evidence about how to treat patients and keep them out of the hospital. So just to remind everyone, we really should be doing a better job of getting patients to treatment, even as outpatients, and really keeping them out of the hospital. Obviously, we mention vaccines and boosters every time we meet. So that goes without saying that we really need to get people over the age of 6 months vaccinated. And we need to get the elderly who are over age 50 boosted and up to date, especially. But really everyone should get a booster, at least one booster. With healthcare workers and those who are age 50 or immunocompromised, they should actually be getting 2 boosters and possibly get another one this fall whenever the newer vaccine types come out. I really think that that's going to be a pretty strong recommendation I don't know if that's happening on my end, but please mute if you're not on mute because I'm getting an echo. The NIH just put out a little bit of an update in terms of what they're recommending, just based on new evidence, and I'll share some of those lines of evidence in the next couple of slides. They're still recommending against the use of steroids, so hopefully we've kind of put that one away. Do not be giving steroids unless you have a really good reason to. And they provide a little bit of a recommendation later on in this table. But in terms of what you should be giving to patients, really the preferred therapy is still Paxlovid. And even if that means stopping other medications for 5 days, patients should still get a course of Paxlovid. Some would say even do it for 10 days if they're really high risk, but at least do 5 days of Paxlovid. If they can't get Paxlovid, then do the 3-day course of remdesivir, which is IV infusion. If they can't get that, then they have a monoclonal antibody called bebtelovimab, which is recommendable. And we do have that available. And some of our clinics are still doing the monoclonal infusions, which is great. And then lastly, molnupiravir still has a role, although it's less effective than Paxlovid. It might be the right fit for patients that can't otherwise be on Paxlovid. Dexamethasone, the baricitinib, which was an older antibody, monoclonal antibody, are no longer recommended. And only if the person is on supplemental oxygen should dexamethasone be given. And that's, a very rare case whenever you send someone home and they're on oxygen. So that's probably not going to happen very frequently. But if you find that special patient who's going to go home on oxygen and the hypoxemia is related to COVID, then you might consider steroids. But even that seems very brave to me. I would probably get them admitted to the hospital at this point, but it's totally up to you. I think the NIH table kind of speaks for itself, and they have a lot of footnotes and explanations, and all of that is found at the link down here at the bottom of the slide. In terms of what came out this week in the New England Journal, 2 articles came out. One that shows that Paxlovid works, and this is, what we've suspected for a long time based on the trial data. And this was, they went back and looked at, I forgot the number of patients. I think it's on here somewhere. It looks like on the order of 40,000 patients. And they basically found that in older patients, treatment definitely keeps people out of the hospital. That different outcome is not really something that was seen in younger patients, like aged less than 64. So they basically stratified according to age, and especially 65 and older patients, Paxlovid really works. You really want to get those people aggressively treated with it and keep them out of the hospital. The other study showed that basically they did a randomized trial. It was kind of an interesting study because they did mix and match combinations of metformin, ivermectin, and fluvoxamine for people who are overweight, not necessarily diabetic. And they basically found that none of these medications helped either by themselves or in combination, which was kind of a surprise because so many people were big believers in ivermectin. So many people were, well, not many people, but there was a vocal contingent who really believed in fluvoxamine, which is basically an antidepressant. And then metformin for many different reasons was advocated as well. None of these really showed a signal that showed benefit. And so the editorial kind of speaks for itself. It just said, time to stop using ineffective COVID-19 drugs. On the one hand, we have effective drugs like Paxlovid. On the other hand, the science just cannot support using these other drugs that people are advocating. So let's stick to the science and stop putting our patients on these ineffective medications. So I just wanted to refer these to you to say the evidence base is getting stronger and stronger. And I think that, with every month that passes, even though these variants keep mutating, we still keep learning more and more about how to treat COVID and how to keep people out of the hospital and keep them alive. All right, well, let's move on unless there's questions about COVID to something that's now called MPX. Formerly, the artist formerly known as monkeypox. The name is now changed, and you're going to hear the term MPX or Mpox. Just because they thought that the old term was too stigmatizing, which makes my slide a little bit less funny, but I still like it. And I'm just going to give you some updates that I've learned in the last couple of weeks. If you're new to MPX, please review the last set of slides that we sent out on August 11th, because there's a lot of information in there that's not in this slide set that will still be very helpful to you to just get oriented about what we're dealing with. Just in terms of the latest statistics, as of a couple of days ago, California now has about 3,000 probable and confirmed cases out of 36 different counties. And the vast majority, I think more than 60% are in LA and San Francisco, the Bay Area having a larger cluster of this outbreak. There have been 81 hospitalizations and no deaths. And many different statistics available about how many vaccines have been distributed and how many courses of the oral treatment called TPOXX have been given. It sounds like more than 3,400 TPOXX courses have been given orally. The US is a world leader, which is, I guess nothing to be proud of, but we are a world leader when it comes to these cases, followed by other countries, mostly in Europe, with a few in South America as well. In terms of the REffective, so you'll remember this is a metric that shows how fast this is spreading. And the REffective was around 3 whenever this outbreak was first described. It's now come down in all over the world, the UK, the US, and places in Europe. And in California, the REffective is sliding down to almost below 1. which is kind of where we want diseases to go, because that means that for every one patient who's infected, there's less than one person who's going to catch that disease from that person. The REffective is hovering around 1.3, but it's still coming down for California. So that's a good sign. That means that, hopefully this outbreak is burning itself out. The bad news is that the modeling shows that we're still going to be on track to have about 16,000 cases in California compared to the 3,000 cases which we now know about. So this is still going to bloom. It's just not going to bloom very quickly. By the end of the year, we'll have 5 times as many cases as we do now. In the Fresno area, we have approximately 17 to 20 cases that are being ruled out / confirmed. We add to that almost every day. The vast majority of them are men who have sex with men, but we know about at least one woman and one basically heterosexual male who has also contracted this illness as a result of sex. So it's still, being passed along through sexual networks. However, it's now starting to break out of that, primarily mode of men who have sex with men with multiple sexual partners, and now affecting other groups as well, which is what we predicted. So expect that story to get more complicated. Again, please go back and review my slides from 2 weeks ago if you need to know more about how it's being spread and how it presents, because I don't really have that in this slide set. What I do have is this slide, which is basically a strategy for success. I still think this holds up, and I still think this link is super useful. This is basically a clinical assistance tool developed by the state just to help you work through all of the different nuances of how it can present. How do you test? What do you tell patients on discharge? How do you work up the close contacts, whether it's in the household or whether it's in the clinical setting? All of that is actually available at this single link, which is why I think it's a super helpful website just to keep on your bookmarks, just in case you need to answer questions for your clinic or your staff or in your other work related to this disease. Another slide that you've seen before, we have lots and lots of documents, and thanks to Sonia and the rest of the PHC team, we're adding really high quality flyers. Please refer to this website for really all of the latest flyers. Some of the information has been updated and changed, especially where people can get their vaccines. But beyond that, we keep adding great flyers. We really just keep them 1 to 2 pages in length, just for ease of reading and for ease of posting. So we want this to be as useful of a toolbox as we can make it for you. Just remember that, think about signage, think about where you're gonna locate these patients. It's becoming more and more clear that, casual contact within the hospital setting is really low risk. And so, you don't necessarily need to keep these folks outdoors, especially if the rash can be covered, especially if it's in their private parts or if they can be kept covered and in an isolated room. You don't necessarily need to keep them outdoors, but if you do have a space to kind of manage them outdoors and take good care of them in their car or outside with privacy attended to, then this might be an example of how you can do that as shown here in the CRMC parking lot. You've seen this slide before. This is basically a one-stop shop for how to do the swab and isolation. And then here's a slide about lab confirmation, which was again something that we presented before. Remember, please practice PPE and swabbing whenever your staff uses gown, gloves, goggles, and N95. They're completely safe, and you can basically just stop your contact investigation right then and there. Is that even if the person comes back positive for monkeypox, all of the staff that saw them, as long as they're using that full PPE, won't need anything else. They don't even need monitoring, although obviously you can inform them just to do your due diligence, but they don't go on to need post-exposure prophylaxis as long as complete PPE was worn. And so that's kind of why it's important to make sure that that PPE is done whenever the swabbing is done. Also remember to rule out herpes and varicella at the time, because co-infections have been described. And we know that many, many patients are discovering that they also have HIV, syphilis, or other STDs at the same time. It's obviously very tragic to find out you have HIV and monkeypox on the same day, but that's being described over and over and over again, is that this might be a presenting infection for undiagnosed HIV. So please make sure you send off that blood test as well on patients who don't know their status. Here's some news flyers. These are basically showing you expanded criteria and an expanded number of doors that patients can walk through to get their vaccinations. Not patients, but basically people that are at high risk. Remember, by the time a patient becomes an MPX patient, it's too late for them to get the vaccine, but everyone that they are close contacts with, meaning household contacts, sexual contacts, et cetera, should go ahead and get vaccinated. And certain high-risk occupations should also go ahead and get vaccinated. What do we mean by high-risk occupations? People that are working in the laboratory and handling these specimens, frontline clinicians like ER clinicians, public health response team members who are going to be interviewing these patients and doing contact tracing on them. If you have an infection prevention team that you are designating to make sure that they go through and do these interviews on these folks, you might want to just go ahead and get them vaccinated so they have that pre-exposure prophylaxis. We actually have enough assets at this point to offer vaccines to all of the people listed in this list. And in fact, we do need to get them vaccinated as soon as possible for several reasons. First of all, that's really going to put a dent in the number of high-risk people who are going to come down with the infection. So people that have a history of sexual diseases that have been diagnosed in the last 12 months, if they're already on HIV pre-exposure prophylaxis, if they've gotten gonorrhea, chlamydia, syphilis, or HIV in the last 12 months, if they've engaged in sex with multiple partners in the last 14 days, males or females, by the way. And certainly we know gay, bisexual, and other men or trans people who have sex with men are definitely at high risk, and we really need them to get vaccinated sooner rather than later. And sex workers of any sexual orientation or gender identity. So again, please take a look at these criteria. Please post these. Be very transparent about them. I've asked my emergency department to just have these plastered all over the break rooms and all over the lobby, just so patients and staff understand who needs to go get the vaccine sooner rather than later. And then we also have a list that our team has put together of all of the provider sites for eligible vaccines. So hopefully you can see that. You can see that we have lots of partnering sites. Thank you so much to all of these sites that are doing the vaccinations. You're all doing amazing work. We really need more providers to be doing vaccinations. If you need more information about what these vaccines look like, what's their shelf life, all of those details are found in this link that's right here. Remember that each of these vials, they can be given subcutaneously, and for that you use the whole volume of the vial. So there's 1 dose of subcutaneous vaccine per vial. But what's really recommended now is that you actually give it intradermally, in which case you can divide that vial into 5 doses. 4 or 5 doses right now, we're asking people to use up to 5 doses, but we understand that sometimes you can only get 4 doses. And all of that is detailed at this hyperlink at the top of this slide. Supplies are limited from what I understand, and one of our immunization team who's on this call might correct me, but we have approximately 3,000 doses that have been allocated to our county. We want to get more, but we can only get more if we use 90% of those. So we really need to get 3,000 people vaccinated sooner rather than later. And so that's why we need more and more people to offer these vaccinations. And if we figure that you are operating in like a high risk space, just because you're seeing a lot of these patients, whether it's because of STD diagnoses, HIV diagnoses, or other or even other high risk populations like the jail, congregate settings and shelters, et cetera, then we're going to knock on your door and really nudge you to start vaccinating and asking you, what can we do to support you? What information and resources do you need to get in the vaccinating game? Because we know that we've got to put out these fires sooner rather than later. And we know that some of our healthcare partners are already seeing these patients. And so we want to make it easy for them to start vaccinating their own high-risk patients to make sure that their staff stay safe and to make sure that our community overall is able to respond to this outbreak. Any questions about that? All right, we'll keep moving here. A couple more kind of interesting articles that have come out. So this one is an MMWR, and they basically asked, how contagious is monkeypox, MPX, sorry, whenever the patient has it We know that they have lesions all over their body. Obviously, we're telling them don't have sex or intimate contact with anyone. Don't spread these juices even to your own eyes, even to your own other parts of your body, but especially to other people, including your household and sexual contacts. But what about all the surfaces? So this basically is so cool. So this team, this is out of Utah. They basically went and just like swabbed the house. They swabbed 2 people with monkeypox who lived together without other housemates. And they basically, these people had MPX diagnosis. And then they basically just swabbed all these surfaces that you see, and they have this nice table where they describe exactly what the surfaces are. And then they basically did a couple of things. They checked the PCR, and then they actually tried to culture MPX virus. And what they found was the PCR came back positive on just a ton of different surfaces, but the culture came back negative on almost everything. In fact, it did come back negative on everything. So the conclusion that they made was these folks are shedding viral particles everywhere, and the DNA is found everywhere. However, it doesn't seem to be a viable particle. And so this should give us a little bit more comfort level about transmission. I think that the conclusion people are drawing is that surface contact seems to be a much less of a route of transmission, that you really have to come by and touch the juice, as it were. I know that that's a very graphic term, but you really have to come by and touch those surfaces right after the infected patient has used them, or else it's really just a non-viable kind of shedding, and it's not really going to go on to spread through that mechanism. And that's kind of what's been shown, with the epidemiology of this illness, is that it's really just a chain that's being propagated by intimate contact, sexual contact, by prolonged household contact, where people are just sharing surfaces without cleaning them in between the people using them, and everyone else is pretty well protected. So that should be a source of reassurance for us in healthcare. Is we know that the PPE is working. We know that people that are using PPE are at extraordinary low risk. And we know that casual contact, especially we worry about that MPX patient being in the lobby, touching surfaces that don't get cleaned very thoroughly, and then someone else comes along and touches those same surfaces. And basically what we're finding is that as long as the skin is intact and not broken, and as long as there's no mucous membrane contact, as long as you don't have prolonged airspace sharing, meaning like 3 hours at less than 6 feet, then you're basically at very low risk of infection transmission. And that should be very reassuring. And so that's kind of the story that's being put together. And although I can't share it today, CDPH is actually putting all this together into a table of risk to say, here's the folks that are at high risk, and they're the folks that have intimate contact or broken skin contact or mucous membrane contact. Here's the folks that are at medium risk, and here's the folks that are at low risk, which is going to be the largest pool of people that we're going to get questions from. And these are the folks that have casual, non-intimate social contact, or healthcare workers that are in PPE and they happen to treat patients with MPX. And we're going to basically recommend that, yes, you did have a brush with this illness. However, you're at such low risk that we're not even going to recommend vaccination for you, because we don't think that you're at risk for getting the infection. So, hopefully this kind of fleshes out more of the story about transmission. It's really a fascinating 2-page article, and I've linked it for you here at the top of the slide. Even before this article came out, our team came up with like a really awesome flyer, which is shown, I'm not sure, oh, there it is, which is about cleaning and disinfecting. This is just a 1-page flyer that really puts it all just in these 5 boxes to say, here's how you need to deal with this to really make your exposure risk really low. Here's how you use your PPE. Here's how you do your laundry. Here's how you clean your hard surfaces and furniture, et cetera. And so that 1-page flyer is also available on our MPOX website. So please look for it there. This is just something great to hand to patients so that they can share it with their household, or to just hand to people that might be anxious because they know someone who knows someone that has MPX, and now they're coming into your clinic or into your lobby seeking help about what to do. And you can basically just say, you know what, this is some good cleaning and disinfection advice that the health department has put together to help you stay safe from MPX. And you can imagine that all our schools, all of our congregate settings, really so many places where this really could get out of control if the cleaning is not done well, really need to benefit from this flyer. And so that's why we want to put it out there. We thought that it was really important that this is so that everyone's on the same page about what the expectations are for doing this cleaning and disinfecting. All right, let's keep going here. And thank you, Sonia, for adding all of these to the chat. In terms of discharge planning, this is a painful rash, as I've said before. Please give them pain medications or they will be back. You know, oral topical lidocaine can help, NSAIDs, acetaminophen, a brief course of opioids like hydrocodone might help. And anticipate complications. Remember that if patients do develop complications or if they're high risk because they're immunocompromised / HIV, that they can qualify to get this tecovirimat medication. And that means if they have an overwhelming rash, if they're developing sepsis, if they're developing pharyngitis causing dehydration, any eye infection whatsoever, any GU infection like urethritis, proctitis, perianal lesions, all of those folks need to get that tecovirimat capsule. Now, it turns out, you know, I shared with you about a patient that I was able to help see along with the ID team who really saw them primarily. And the ID team actually handed them a bottle of this stuff in the parking lot of CRMC. It turns out that this morning, that gentleman was in communication with our communicable disease team. And now he says that, you know, it's been a couple of weeks and his sores are totally healed up. So he's cleared, he's going to be cleared and he'll be able to get back to his daily activities. But this is sort of the natural history of what happens, you know, is that these folks do respond quite well to this antiviral. They do clear up their scabs and their rash much faster, and they get back to, you know, having a pain-free period much quicker whenever they get on this medication. So I thought that that was a nice closure to that case, although we know that many more, you know, a few dozen more cases have since been described in the Central Valley. Since my last talk, we've put out this health alert, which is super duper important. You've already gotten it in your email. If you haven't, then we'll reshare it with you, or we'll put it in the link. This is a really important one to read through. And I really like that this starts with very general information about what is monkeypox, what is MPX, how does it spread, what are the signs and symptoms, and then it gets into who needs to have specific antiviral treatment. And basically the last page of this health alert, which is from August 19th, has very critical information that's new that you really want to keep on hand. This basically gives you the checklist of people who should be considered for the antiviral treatment and how to get them the treatment. And the good news is that since our last talk, the IRB at UCSF Fresno has approved the investigational new drug application. And now this team can go forth and really provide this medication in several different ways. First, they can do telemedicine and find this patient over telemedicine. Second, these patients can be seen at the Mobile Heal site, which is also quote unquote called the COVID Equity Project, which is operated by my UCSF Fresno Emergency Department colleagues, Dr. Bond, Dr. Dillon, and their amazing team who are doing vaccinations out there. Well, now they can also do the TPOXX treatment assessments in conjunction with the UCSF ID team. So remember, the UCSF Fresno ID team will need to be present to consent the patient for the investigational new drug protocol and then to actually hand them the pills. But this can be done in several different ways. If they can't find a place to meet with this patient, they may have the patient come back to your clinic and just sit out in the parking lot and then meet them there or figure out some other way to do that. The best way to figure all of this out is to call Dr. Geeta Sivasubramaniam or her study coordinator, Alyssa Hughes. And those numbers are shown in the bottom right of this slide. They're very generous with providing this information to the whole medical community here in Fresno County. So thank you so much to Dr. Geeta, to Alyssa for this Herculean task and really maintaining such a high standard of care for all of our patients here in Fresno County that they can basically be just a phone call away from getting this cutting edge treatment. Please call them during business hours, not on the evenings or the weekends. Really, if you're seeing a patient in an emergency or urgent care setting on the evenings or the weekends, all you really need to do is to just treat them for pain and then have them follow up on Monday morning. And really Monday through Friday, 8 to 4 is when this program is going to be operational. And the UCSF Fresno ID team is going to be able to consent that patient over the phone if we can establish a good phone connection. If we can't, then we may need to see them in person. And again, we have several different spots where we can probably see them. But if we can't figure that out, then we'll ask them to come back to your site, and then we'll be able to coordinate care for them there. I know that that's more cumbersome than we would like, but that's just part and parcel of this investigational new drug protocol. I think someday soon, we don't know when, but someday soon, the FDA is going to grant an emergency use authorization. And even though that's not full approval, the emergency use authorization will basically permit any clinician to prescribe TPOXX. And any clinician can prescribe TPOXX, and any pharmacy can store TPOXX with that emergency use authorization. So that's really the next step that's going to change this process. We don't know when that will come. That might be still several months away. I certainly hope that it's sooner. And so until then, please utilize this process that we've set up in place. We worked really hard to get this in place. Certainly loop us in at the health department, our communicable disease line. My cell phone number is listed there as well. You can text me or call me or email me, and I can try to help link you in. Remember, Kaiser and the VA are also doing this. So if your patient is a VA patient or your patient is a Kaiser patient, then they basically can go to those facilities as well to get access to this treatment. We know that several other multi-county clinics are going to offer this, like Dignity Health, Sutter Health, et cetera. So this process is getting expanded and scaled up at the statewide level. Right now, this seems to be the best plan that we have in place, and it's all summarized in this slide. Again, you should have this over your email. Please look at this document, and please bookmark this last page of this document so you know exactly where to find these folks whenever you have those patients that require the antiviral treatment. Any questions about that before I switch gears and talk about other infections? All right, and we've linked into this health alert to your chat as well, so you can pull it down from your chat. All right, any questions? All right, well, lots of other infectious diseases in the mix. I don't know if you've been following the headlines, but there's a lot going on. You know, my new joke is, I don't know what I'm going to miss more, Dr. Fauci or COVID, because there's so many new infections now that I feel very out of already my comfort zone was being pushed, and now my comfort zone is being pushed even more because there's so many other infections now to keep up with. First, flu is coming back. It's right around the corner. Flu season is about to start in just a few short months. And so coming soon is our flu order for the year. This is going to look pretty much exactly like our flu order, which we did last year, which you can find at this link right there. The language, the requirement, the exemption clauses will be basically the exact same with perhaps minor tweaks. And obviously we will update the dates and the new badge color for those who are in the badge color planning process is brown. So I don't know if that helps you. I hope it does. You've already started to ask us questions about the badge color, and now you know the badge color this year will be brown. We're going to be working on this flu order. Look for it to come out hopefully in the next week or so. Some of you are already getting vaccines shipped to you, and that's wonderful. Please plan your employee vaccine clinics. That's a huge shield that we have, and it really keeps people safe. We've done so well for the last couple of years with our flu shots. Let's keep that going. I really want to repeat the victories that we've had against influenza for the last 2 winters, but we've got to work as a team to do that and really get your employees vaccinated. Get all of your high-risk patients vaccinated. You know, if they're coming to you with a sprained ankle or a headache, go ahead and talk to them about the flu vaccine and get them done. You know, get them pushed out to a place that can do flu vaccines or offer flu vaccines to your patients in-house. Do whatever it takes. We really need to get everyone over age 6 months to get their influenza vaccine this year. We know that it's worked last year and the year before. We just need to do it again. And get those masks back on once the fall season starts. Obviously, the masks are still required in our healthcare setting, but really beyond the healthcare setting, we really need to bring masking back in a big way, not only to protect against COVID, which we know is still circulating, but also against influenza, which we know is going to start acting up again. And unfortunately, if people aren't masking the way that they did last winter, we can expect increased influenza activity this year. The MMWR just dropped. Actually, it hasn't dropped yet. It's going to drop tomorrow. This says August 26th. However, they sent out early access to it, which is linked to you at the bottom of this slide. And this basically is a nice document that gives you the playbook for influenza planning this year. And it gives you really the list of all of the different vaccines that are now available on the market, which patient group should get which one, depending on if they're immunocompromised, if they have any special needs, et cetera. And it gives you lots of good information and up-to-date recommendations about how to handle flu this year. So please look for that. This is coming from the CDC and the ACIP, and it's available now on the MMWR website. All right, and this is the health order. I just put this in there for completion. This was the health order from last year. Like I said, it's going to look pretty similar to the one that we're crafting this year, and I should have that signed in the next few days. Bird flu has also landed. So this is not the other flu. In fact, it actually does not respond to the influenza vaccine. This is a different kind of flu called the avian flu. And guess what? We just found out a couple of days ago that approximately 34,000 chickens in Fresno County have had to be euthanized because the avian influenza was discovered in these flocks. That's really all the information that we have access to. You can see here that it's actually the Department of Food and Agriculture keeps a really good table of all of the bird flu detections by day, and whether it's happening in a commercial flock, in what's called a backyard flock, and how many number of birds are affected. Usually the number of birds is like a few dozen, maybe 90. And then you look at Fresno, and of course, we've got to be better than everybody else. 33,000 birds, 33,900 birds. And they're all just, having to be euthanized. I don't think they can go to Chick-fil-A or any of our lovely chicken restaurants. I think they have to be destroyed and not used. And so that's kind of the fate of those animals. Fortunately, no human cases have been precipitated or detected as a result of this specific cluster. However, our monitoring and our investigation is ongoing, something that we're just learning about in the last few days. And so you may hear more about this story as it kind of unfolds. However, it's already out on the media, and there's already press releases that have been crafted from the state level. And so it's really, for those who want this information, it's available freely online. And I've kind of linked to good information that you might get questions about. I think the bottom line for all clinicians is, if somebody comes down with flu-like illness, you're definitely going to test them for COVID. If you're like me, you're definitely going to test them for influenza, but you also should be asking about handling poultry. Do you keep chickens? Do you work with chickens? Are you working with poultry in your job? And if they are, then please call us on the communicable disease hotline, because we may be very interested in finding out more about where that person works and whether that is a workplace that we're monitoring currently. So that's, I think the takeaway is just ask the questions. You don't necessarily need to do the testing, et cetera, unless we recommend it. And if we do recommend it, then the testing has to go to like the state and the CDC, et cetera. So it's kind of a headache to do testing for avian flu. However, we want to do our due diligence. And if there are any cases that percolate from, our clinical partners, we definitely want to be involved in the workup. So reach out to us sooner rather than later if something in the history kind of raises a red flag about bird flu, because it is now being found in Fresno County. West Nile virus, still buzzing. So what is West Nile virus? It's basically spread to people through bites of infected mosquitoes. Hundreds of mosquitoes have been found with this now in the Fresno County area. This has been really something that was detected several months ago, and we mentioned it on media. Well, it turns out there's been several dozen human cases. So in Fresno County, the stats are shown for you down here: 9 confirmed, 6 probable, and 6 suspected cases, including 1 death from what we call neuroinvasive, meaning they basically have meningoencephalitis. and one other possible death that we're also investigating. That's not super public, so please keep that confidential, but we are working on a press release, and we will be sharing that with our partners in the Mosquito Abatement District to just kind of tell the full story, but we want to do our due diligence and just confirm some of these statistics before we put out the final numbers. But just, again, clinical takeaways is suspect it, ask about it, include this in your workup. If you're working up someone with a CNS infection and everything else comes back negative, you really should be thinking about West Nile virus and sending off the testing for that. Just remember that it's really the extremes of age, very young and very old folks that we worry about. Lots more information can be found at this website below. Cocci, so fungal infections also are making the news and making the rounds. This is another new article from the MMWR. This is really interesting because I've always, I've been talking about climate change and the health effects of climate change. And here you see that it's not just the usual stuff, it's also these infectious diseases that are more or less, exotic, possibly not as common as the bacteria and the viruses that we're used to dealing with. But it turns out valley fever is super common in the Central Valley. And here, this actually happened in firefighters. So they discussed a fire that was in Tehachapi, and the fire only lasted like 3 days. 40 firefighters worked the fire. 7 presented multiple times to Kern County and surrounding emergency departments with shortness of breath, flu-like illness. This was in 2021. So obviously they got ruled out for COVID. But guess what? 3 out of those 7 got hospitalized, and all 3 were positive for Cocci. So this was basically, they did an investigation. This was a great partnership between CAL FIRE and CDPH, and they went back and did an investigation, and it turns out that all of these folks were involved in digging trenches, mopping up the fire, which includes digging and moving soil with heavy dust exposure and without respiratory protection. You can imagine working on a fire, you really don't want a lot of masks and stuff. In fact, masks can actually be seen as a hindrance to just the exertion that's required. But unfortunately, they didn't have that respiratory protection. They were breathing in dust, and along with that dust, spores of coccidiomycosis. And all 3 required treatment with fluconazole and a hospital day of 8 to 17 days. This is probably going to happen more and more. I think this is the whole of the article, but somewhere in here, they basically just make the conclusion that's a little bit obvious when you think about it. As wildfire activity increases in the Central Valley, this is going to happen more and more. So we can expect that this is something else that, we should be attuned to. I just thought that this was kind of a neat article that shows just another dimension of the health effects of climate change. And finally, polio. Okay, so the one piece of good news is we don't have polio in Fresno County that I know of yet. However, the news around the world is not good. Wastewater surveillance is showing positivity in metro areas in New York City, London, Jerusalem, and you can bet your bottom dollar it's probably in Los Angeles. We just haven't detected it yet. The clinical disease in New York State is very interesting. It was really due to community spread. So the way that they track that back is because the strain of polio that was detected in New York State is only found whenever people are shedding it. And it's not found in the wild type polio that we've seen around the world, especially in countries like Afghanistan and Pakistan. This is really the kind that's related to shedding oral polio vaccine related virus. So remember, when people around the world get vaccinated, they don't get the inactivated intramuscular shot that the Americans get. They actually get a live oral vaccine. It's just a couple of drops in the mouth. That actually causes a latent infection and shedding of usually weak, non-pathogenic viruses. However, those non-pathogenic viruses mutate like all viruses do, and sometimes they mutate into a paralyzing strain. And that's the strain that was actually detected in this New York case. So they know that this patient who basically developed clinical polio paralysis was actually a victim of shedding of a pathogenic strain from someone who got the live oral vaccine probably somewhere else in the world. And many, many countries use the live oral vaccine. They're not really disclosing, or I haven't been able to track back which country this linked back to, et cetera. But that almost doesn't matter because so many countries use the live oral vaccines. It's a fascinating story. The New Yorker has a great article about it. Nature has a great article about it. I'll try to link to it whenever I send out these notes. In terms of who's at risk on the West Coast, well, CDPH is now starting to do wastewater surveillance, but they don't have any data yet. They spent a whole 15 minutes on our call yesterday talking about polio. So you can tell that this has reached the highest levels of attention in the state of California, because I think they absolutely anticipate that they're going to describe polio happening on the West Coast the way that it has in New York and London. People that are non-vaccinated, so whether they were born in the US or whether they're coming from other countries, from the Middle East, Asia, the Ukraine and Russia, there's actually a lot of people that are kind of refugees from these countries that have settled in parts of Central California. So they're really worried that these non-vaccinated populations are either going to get polio or they're going to catch this, this sort of weakened strain from one of their relatives or neighbors that comes over and has it. And then basically they're going to incubate a weakened strain, which then mutates into a paralyzing strain. So it's kind of a sensitive situation. However, the best we can do is just ask the question, are you vaccinated for polio? If not, let's get you vaccinated, regardless of where they come from, regardless of what their age is. The other sort of bummer about this is that because of the COVID pandemic, we really lost ground on pediatric vaccinations of US born children, to where now, it's basically 5% lower than it was in 2020. So in 2 years, we've lost 5% of our usual, and it's never 100%, but it's up to 90, 94%. However, it's 4 to 5% less whenever they look at the polio statistics in California. So that just increases the pool of kids that are now vulnerable to polio. It's a little scary, and it's a little maddening that we haven't made more progress and learned more about how to beat back polio. The CDC actually has a webinar scheduled on September 1st, which I just found out about. So the very bottom line of this slide links you to that webinar. Please watch it or catch it after the fact, because they always stream it. They always share out their slides. It's one of those Coca calls where they just do an amazing job with world experts. So if you want to just catch up on what you understand about polio and figure out how to get kids vaccinated, they're going to cover both of those topics on this September 1 webinar from the CDC. And I just found out about this virus. It's a real virus called the tomato flu. I just Google it. I can't even do it today. I was astounded. This might be another virus that's just taking off. And I just thought to myself, please, if I could just have 1 week without a new disease, I would consider that a victory. Anyway, I'm happy to take questions. Thank you for listening. I'll send out these notes shortly after these slides, shortly after we adjourn. All right, let me go through and ask some of these questions. Yeah, Chris is asking a great question. Why don't we have a vaccine for West Nile virus? And I don't know, Chris. These mosquito-borne infections, I have to tell you, they're pretty clever. Malaria is another one that we don't have a vaccine for, and that's a mosquito-borne infection. So I don't know if it's just something about those organisms that makes that very hard to vaccinate against. I'm not as familiar with the immunology of West Nile. I know why, but I remember being a resident and first learning about West Nile, which obviously comes from the Middle East, now gaining a foothold in the US and basically creeping across the territory of the US from east to west. I'm just not familiar with the immunology to understand why.
Yeah, I always assumed that malaria, because it wasn't a virus, it's actually a one-cell organism, right? And so I don't know of any vaccines against non-viral cellular organisms, but yeah. West Nile is a virus, so I just wondered that, why we don't have anything yet. But I guess you're right; it's just proven difficult.
Julie is asking, has the CDC said we can stop surveillance testing of non-vaccinated staff in healthcare settings? As far as I know, CDPH and CDC have not changed that recommendation. So I can confirm that, Julie, but you know, that's really a CDPH question. And as far as I know, they haven't put out any updates on COVID surveillance for non-vaccinated. And then I think there was a question at the very top. Dr. Tran was asking, if you've got 2 boosters already and COVID positive in the last month, do you still need the new booster? That's a good question. You probably don't, Dr. Tran. What I've found is that people that get COVID infection and survive actually have a really good immunity, even despite these new variants, to where even if they catch another infection, it's going to be very mild and minimal for them. We're not really seeing people land in the hospital due to reinfections after having survived another one. And so I think for what it's worth, if you've already had 2 boosters and now you're immune to a very recent strain of COVID, which is what it sounds like, then I think you should be good and you could probably relax a little bit and not worry about getting a booster this fall. Having said that, you know, the new vaccines are going to be targeting both the Alpha and the Omicron strains. That's why they're called bivalent, is because they're basically against both of those major variants. And so for many of us who are only vaccinated against the original COVID strain and haven't gotten the vaccine specifically against Omicron, especially BA4, BA5, getting the bivalent booster is probably going to be something that many of us are looking forward to. The Novavax, even though it was basically designed against the Alpha variant, because of the technology that they use, is still supposed to be very protective even in the Omicron era. And the Novavax is something else that is just on the cusp of being available widely. And that's something else that, you know, hopefully in the next week or so, we will have available here in Fresno. I've got a question out to my immunization team about when Novavax will be available. And so hopefully next time we meet, we'll have more information about where you can get Novavax, which is not bivalent, but it's still considered pretty good against the latest variants. So I don't know, I think everyone has to do their own risk assessment at this point. Certainly if you haven't gotten even a single booster, get that right away. If you're a healthcare worker older than age 50, I think you should go ahead and get a second booster, or immunocompromised, then you should go ahead and get a second booster. And then for everyone else, just depending on, you know, what is your COVID history and what is your risk at work, et cetera, and what is your own personal risk tolerance, then I think, you know, that will guide your decision making about getting the Novavax or getting the bivalent booster whenever that comes out later this fall.
Do we have any new information, Dr. Vohra, regarding like the natural immunity once you get it? Do you know how long it lasts?
We really don't have great data on that. I've heard anywhere from 6 months to 18 months, possibly longer. You know, then again, you meet many people that have gotten COVID twice. Mm-hmm. So, again, I don't know that I have any good articles that I can point you to. All I can tell you is that it seems like the reinfections are not what's driving the hospitalizations. Hospitalizations are still people that are just not vaccinated even once. So for what it's worth, I think, you know, like other viruses, like influenza, et cetera, once our species as a whole, our population has more with these viruses, they're going to become something else that, you know, we all develop a little bit of immunity to. And then, you know, whenever we do catch a new strain of it, hopefully we'll still be able to have some residual immunity to fight back and not land in the hospital. So I think that's where all this is going, is that, you know, we'll never be done with COVID, just like we'll never be done with influenza, but the vaccines will keep us out of the hospital, and it will keep whatever infections we do catch to be more of a nuisance rather than a real danger to life and health.
Thank you.
Sure, thank you. Any other questions, comments, announcements? Christoph reminds you to give blood or help host a blood drive. It's interesting because I think that the blood center must test for West Nile because out of those cases, several of them, I think like 3 of them were completely asymptomatic and they were just picked up in the blood donation process. So that was kind of interesting to read about.
That's one way that blood banks all around the country help with public health.
So that's a nice surveillance tool.
Mhm.
So you can find out if you have West Nile and you're asymptomatic just by donating blood,
Mhm.
and help save some lives too.
Thank you.
Great. Well, it's always great to hear from you folks. Please, look out for these notes whenever we send them out. I think we've given you plenty of homework reading in all of these links. So thanks to Sim and Sonia for keeping up with comments. And we'll see you hopefully, if not next week, then the week after. In the meantime, check your emails because we will send out health alerts and the health order for influenza as soon as it's ready. Thank you so much. Take care.